Sarah Moore. Sarah is one of our infectious diseases pharmacists here at Norton, and she decided to tackle a topic that is a challenge for anyone working in healthcare, the topic of viral illnesses and antimicrobial stewardship. Sarah?
All right, thank you, Dr. Ramirez. So one of the reasons I wanted to talk about this today, as Dr. Ramirez has said, this is a huge challenge in healthcare as far as how to best address it because of how widespread the issue is. That being said, it is one of the things that's a little bit more straightforward in antimicrobial stewardship. So I'm hoping that we come away today all feeling a little bit empowered about how to address it. So the first thing I wanted to start with is just some selected epidemiology of viral illnesses. Now, this is not all encompassing of the viral illnesses that we will see, but these are one of the ones that is more readily diagnosed here in the US. So first, I'll start off with our old pal influenza. In our most recent flu season, we saw somewhere between 8 and 13 million infections, somewhere between 80,000 and 170,000 hospitalizations, as well as 5 to 14,000 deaths. And then over on our RSV side, in 2021, we saw over 120,000 confirmed infections. That being said, Dr. Ramirez is also doing some ongoing research, which may suggest that that might be an underestimate as well, and we may actually have more RSV cases than we really even fully appreciate. And then, of course, I think we're all aware throughout the COVID-19 pandemic that we've had over 90 million infections, as well as over 1 million deaths here in the United States. And that doesn't even fully encompass our global burden of illness. So even without throwing in all the many other viruses that we could worry about, I think it's pretty apparent that viral illness causes significant morbidity and mortality here in the US. However, an antibiotic is the wrong tool to treat a virus. So similar to cutting up a cantaloupe with a power drill, giving an antibiotic in the setting of a viral illness is not an appropriate thing to do. So this is from the CDC's antibiotic awareness campaign. So they every year release materials and have a week in November to try to emphasize this point, both to the public as well as healthcare practitioners. I always really liked this particular one because I think it makes the point pretty eloquently. They also have some other materials as far as education. This one's probably a little bit more geared towards patients, but it looks at what's got you sick and is it likely to be a bacteria where we would give antibiotics or a virus where those would probably not be necessary. So situations like a common cold, runny nose, sore throat, or of course, COVID-19 or influenza, we have a viral illness and antibiotics would not be appropriate. They do have some situations where maybe they note that those would be potentially appropriate to give antibiotics. And then they, of course, also note things like strep throat, which is a bacterial infection and antibiotics would be appropriate. So sometimes some of these materials may be helpful to us, especially when interacting with patients, to help explain why an antibiotic wouldn't be appropriate. So in addition to CDC, we also have IDSA guidelines, which try to help us address this question about should we give antibiotics or not. Now, in the 2012 rhinosinusitis guidelines from IDSA, the very first question that they address is, how can I tell if this is a viral versus a bacterial infection? So this is the number one question top of mind when addressing this particular disease state. These guidelines note that there's a few things that more likely could be associated with a bacterial infection. And the first of those is just a longer duration of symptoms. So if this infection has been hanging out for more than 10 days, it's more likely to be bacterial versus a virus. We tend to see those just resolve more quickly. The other things that they note would be severe symptoms. So things like very high fevers, purulent nasal discharge that persists for more than 3 days from the very beginning of symptom onset. And then the last thing they know that may also be associated with bacterial infection could be if a patient has their initial symptom onset and then they start improving and feeling quite a bit better and then start feeling really crummy again then that might be indicative that we had a viral illness that we're starting to recover from, and then a secondary bacterial infection set in. So overall, these guidelines would encourage us to not start antibiotics unless a patient meets any of these criteria listed. So moving on to our community-acquired pneumonia guidelines, which come out with the IDSA and ATS put these together as a team. These were most recently published in 2019. They don't address viral illness quite as robustly here, even though viral pneumonia is certainly common, but they do actually specifically suggest an algorithm when it comes to patients with severe pneumonias and diagnosed influenza. What they have is if a patient does have confirmed influenza, antibiotics may be stopped after 2 to 3 days if the patient's overall clinically stable and improving, and there's no evidence of a bacterial pathogen present. So cultures are negative, biomarkers such as procalcitonin wouldn't suggest that we have bacterial co-infection that would be appropriate to stop. And these guidelines specifically address influenza, probably because that was our most commonly diagnosed respiratory virus at the time. But I think that there are a lot of folks out there, probably myself included, that would say we could apply some of these to other viral illnesses, such as COVID-19 as well. I think that the algorithm suggested still is reasonable in other viral illnesses. So taking a step back from viruses, let's talk a little bit. So what we have here is community antibiotic prescriptions per 1,000 people by state. This data is from 2019, and a darker color would indicate a more frequent antibiotic prescription. So as we can see here, Kentucky is the darkest color that there is. And what we know is that our number of antibiotics used per our population here in Kentucky is much higher than other areas of the United States. So based on this data alone, we don't know that all of those antibiotics are inappropriate, but we do have some more drilled down data that would suggest that we're an outlier and probably not in a good way. So the first study that I want to talk about is actually a retrospective review of Kentucky Medicaid claims done in the 1990s. And the reason I wanted to include this is because sometimes we talk as if antimicrobial stewardship is a new concept, but we had colleagues 30 years ago studying and publishing on this. So overall, this isn't new information to us here, even in our state. But what these researchers did is looked at outpatient and emergency room visits for acute nasopharyngitis, which they were using essentially as a surrogate for likely viral illness. And they didn't think that antibiotics would likely be appropriate there. What they found is that 60% of the time, those visits resulted in a fill of an antibiotic prescription. Based on their data as well, adult patients and those in urban settings were more likely to actually receive antibiotic prescriptions as well, which is going to be in slight contrast to this more modern data. So again, this was a retrospective review of Kentucky Medicaid claims 2012 through 2017, but this time just in pediatric patients. So this was done by some of our colleagues over at U of L and yielded slightly different results in who was most likely to get antibiotics, but probably still tells us that we have some opportunities as far as appropriateness. So in this study, rural areas were more likely to have antibiotics prescribed. In Eastern Kentucky, the antibiotic prescription to child ratio was 3 to 1, which is pretty staggering. And then in this case as well, they also noted that most antibiotics were prescribed by nurse practitioners and general practitioners rather than pediatricians. In the article, though, they also discussed that some of that may just be driven by the availability of pediatric providers in the area. Given that it's more rural, there may just be less access to those pediatric providers. They also did a drill down on 2017 and tried to estimate the appropriateness of these antibiotic prescriptions. So again, use alone doesn't necessarily tell us that it's all inappropriate, but based on that more detailed information, they were only able to determine that 45.9% of those prescriptions were appropriate. So meaning we probably still have some progress to be made as far as appropriate prescriptions for viral illness here in the Commonwealth. So shifting gears slightly from Kentucky, I want to talk about some antimicrobial stewardship interventions that have been done for various viral illnesses around the world and how those have worked out or haven't. So the first is going to be influenza and antimicrobial stewardship. And the study that I'm going to talk about first is actually comparing two different ways of diagnosing influenza and what happened with antibiotic prescriptions. What they had was a multiplex PCR test that had to be sent to a lab and had about a 24-hour turnaround time. And we're trying to compare it to a rapid point of care test that had about a 2-hour turnaround time. So the researchers were postulating if we have that diagnosis of influenza much sooner with that rapid point of care test, maybe we can decrease antibiotic use because hopefully information is power. So they were able to demonstrate that. Overall, antibiotics were initiated in 51 to 67% of patients, with that higher end being the folks who received the less rapid test. However, I think the interesting thing about this study is even when we knew these patients had influenza, antibiotics were still given in the majority of cases. So even when we have that diagnosis of viral illness, we still have this tendency to just say, well, we're going to give the antibiotic just in case. So this was a similar study, again, looking at influenza. This one was an open label randomized controlled trial, again, done in the UK in 2015 and 2016, and comparing those two different turnaround times as far as the tests. And this one, we saw even higher antibiotic prescribing rates. So 83% in the rapid point of care testing group and 84% in the standard of care arm. So overall, in both groups, we had a mean duration of antibiotic therapy of 7 days. So even though we had positive influenza tests, antibiotics were given in the vast majority of cases for a full course for a bacterial pneumonia. Overall, it looks like there was not a ton of impact on that turnaround time of the test, helping curtail antibiotic use. The only difference between the groups, though, was in the rapid point of care group test. We did see there was more frequently just a single dose of an antibiotic given. So that happened in 17% of those patients versus 9% of the slower turnaround group. So I won't say there was no impact whatsoever of that more rapid influenza test, but probably not quite the degree of impact that we might have necessarily hoped for. Which brings me to our more modern challenge as far as viral illness, which is the COVID-19 pandemic. So interestingly enough, in the spring of 2020, there were some antimicrobial stewardship experts around the world who were writing think pieces about what's going to happen as far as stewardship throughout the pandemic. And they essentially argued that this pandemic was going to be a perfect storm for loss of good antimicrobial stewardship and the development of bacterial resistance. And the few things that they were worried about are listed here on the slide. So first, antimicrobial stewardship staff and infectious diseases experts being reallocated for pandemic response, which is exactly what happened here at Norton Healthcare. I know that's what happened to our colleagues around the city and around the country. And though that was completely appropriate, because I think that infectious diseases experts are the right people to bring to the table to respond to a pandemic, it meant that there's not as much bandwidth to do those standardized stewardship activities. And they tend to just fall by the wayside. Again, early in the pandemic, we also had low rates of bacterial co-infection alongside COVID-19 being reported, with very high rates of antibiotic prescribing, which would suggest that that was widespread inappropriate antimicrobial use. The other piece that they brought up was because pretty much every patient in the hospital was in isolation, and that was more burdensome to staff, that they may not be quite as diligent about isolation when it came to patients who had non-COVID-19 multi-drug resistant infections. And the last point that they brought up that I think is a little bit interesting was prescriber anxiety and burnout potentially contributing to antibiotic overuse. And though this is much more difficult to actually study or track, I will say anecdotally, in having conversations with physicians throughout the pandemic, I think it's something that probably really did contribute, especially if a patient is critically ill, and it's in line with our goals of care to do absolutely everything we can, there sometimes is this idea in the back of our minds, oh, well, like, what if it is a secondary bacterial infection? There's essentially perceived low risk of giving an antibiotic with potential high payoff being if you've missed some sort of diagnosis. The reality is that most of these patients are just sick with COVID-19, and that anxiety that we've missed something probably is very unlikely that that's actually the case. But these stewardship experts overall were right. So what we found is in this report released earlier this year that we have seen an increase in multi-drug resistant organisms throughout the pandemic. So overall, a 35% increase in carbapenem-resistant Acinetobacter infections, 60% increase in Candida auris, a 35% increase in CRE, and 32% increase in ESBLs. So we had been making progress on decreasing these multi-drug resistant infections leading up till the pandemic. And unfortunately, that progress has very rapidly been reversed. So I think this emphasizes the importance of good antimicrobial stewardship in the setting of the pandemic and in the setting of viral illness, because it's very easy to see how quickly we can backslide. So just to emphasize, antibiotics don't work to treat COVID-19. This is a viral illness, and antibiotics are not appropriate as part of routine management. But there exists the question, could a patient have COVID-19 and a bacterial co-infection? And the answer is technically yes, that is possible. Overall, COVID-19 and bacterial co-infection rates are reportedly less than 10%. The largest meta-analysis to date estimated that it's probably about 8%. However, antibiotics have been prescribed in up to 84% of COVID-19 patients. So there's a huge disparity between the amount of antibiotics being prescribed and the actual rate of bacterial co-infection. The interesting piece about this is I will call up providers and say, hey, you've got your COVID patient on antibiotics. Do you think we can stop? And some of that anxiety does come into those conversations because prescribers will often tell me, well, I have seen these patients where they do have bacterial infections too. And the reality is, I don't doubt that. With the volume of COVID-19 patients that they've seen, I would be very surprised if they haven't seen any patients with viral and bacterial co-infection. But the fallacy there is in treating that like the rule rather than the exception. Additionally, there was a survey done in 2020 of physicians, and the respondents overall stated that they believe that COVID-19 patients needed an average of 7 days of antibiotics, so a full course to treat a bacterial pneumonia. Despite this data listed above, that's probably not necessary. So something here just really isn't adding up in terms of what the data is telling us and how our practice is actually being carried out. So is there any hope? Yes, overall, I would say so. So challenging the notion that antibiotics are needed in patients with viral illness can actually lead to behavior change. So I wanted to share a study that we actually did here at Norton Healthcare. And this was a retrospective review comparing outcomes with patients who, after they got their COVID-19 diagnosis, either had their antibiotics continued early or late. And the way that we defined that was from the COVID-19 test going into the electronic health record, once that result was available to our prescribers. If antibiotics were stopped within 48 hours, that was our early discontinuation group. If they were stopped after 48 hours, that was our late discontinuation group. And what we found was that there was no difference in mortality or length of stay, regardless of whether antibiotics were stopped early or late. So what that tells us is it's probably appropriate to just go ahead and not give that full treatment course, even though that might be our instinct, because it seems to be relatively safe in terms of outcomes. One of the other interesting findings in this study was that we looked at our antimicrobial stewardship recommendations and what had happened with those. We didn't see a significant difference in the number of recommendations made between that early and late discontinuation group, but what we did see was a difference in those acceptance rates. So in the early discontinuation group, our acceptance rate was 74%, versus in the late discontinuation group, it was only 54%, and that was statistically significant. So what this suggests to me is that providers or anybody who's prescribing antibiotics, utilizing the stewardship program and interacting with us in good faith, letting us help guide those practices can actually really have an impact. And again, I mean, obviously, there's not a lot to celebrate as far as stewardship through COVID. I think that that's really apparent from the high level data, but I think that this is one of the results that speaks to the value of any of us questioning these prescribing practices in the setting of COVID-19. So the last thing that I wanted to discuss would be helpful ways to differentiate bacterial versus viral infection. So the first thing we can talk a little bit about is procalcitonin, which is an inflammatory marker. Seemingly, it's a little bit more specific to bacterial infection than some of our other inflammatory markers. And it has been utilized in our COVID-19 patients to help curtail some antibiotic use in those folks. So this first study was a little bit smaller and was done in critically ill patients in the UK. And what they found was when they utilized procalcitonin and stopped antibiotics if it was low, that they were able to shorten their duration of therapy, again, in these critically ill patients from about 7 days down to 5. And that was statistically significant. There's a more recent study that just came out that looked at procalcitonin as both a negative and positive predictor for bacterial co-infection. And what they found was that we can see procalcitonin elevations in these COVID-19 patients without any real bacterial co-infection. So seemingly, even though we think it's a little bit more specific to bacterial infection, they weren't able to find any other definitive evidence suggesting that procalcitonin may not have a great positive predictive value in those folks. This study did also reinforce that if procalcitonin was low in these COVID-19 patients, that they were extremely unlikely to have a bacterial co-infection. So its negative predictive value was still seemingly very good, which is what we would expect based on past studies. The other piece that we might look at would be negative cultures. So if we're checking sputum and blood cultures in these patients, if there's no bacterial growth or no growth outside of our normal respiratory flora, then we can probably feel pretty good that it's less likely that this patient has a bacterial co-infection. So the last piece that would be just my charge to all of us as a group. So what can we all be doing? The first thing I think is just setting a good example. And this comes both from a professional standpoint as well as a personal standpoint. So in our personal lives, if one of us has a sore throat, the first call should not be, hey, I need an antibiotic. It should be utilizing those evidence-based guidelines and applying them to ourselves as well. I think where that also comes in is obviously in our practice as healthcare professionals. So if we have a patient who, say, comes back positive for COVID-19 and their procalcitonin is low, cultures are negative, and I go to a prescriber and say, hey, I think it's appropriate to stop antibiotics. What do you think? Sometimes I'll get the response that's, it's already day 5. Let's just treat for a full 7. And I would say that that's really letting inertia guide our practice rather than good evidence-based medicine. And I think that that's important to kind of challenge that notion a little bit and say, okay, well, this is what evidence tells us. Let's set a good example to our team and to the other prescribers around us and actually prove to ourselves that this is a safe and appropriate thing to do. And then the last piece would just be educating our peers. So we've talked about this in earlier stewardship presentations, but there tends to be sometimes this idea that antibiotics are relatively benign medications, which is absolutely not the case. We do have issues associated with antibiotics, and those can be short-term harms like antibiotic side effects or the risk of C. difficile infection, as well as the more long-term threat of antimicrobial resistance. So again, I wanted to talk about this in the setting of viral illness because it's a little bit more cut and dried that antibiotics are probably not appropriate, as well as just given that widespread burden of viral illness, it's something that's absolutely going to come up for all of us. So again, just want to emphasize the challenge to all of you that we should not be giving antibiotics in viral illnesses. And if we're seeing this happen in our practices, that it should be something that we're bringing up and questioning and just asking ourselves if we can do a little bit better. So with that, I will take any questions that anybody has.
It's very good. If anybody has any questions, please drop those into the chat. I know that you mentioned, Sarah, the report about antimicrobial use in Kentucky using the Medicaid data, and I know that's also, I think, was recently the update just confirms what you said, that some of the IPs in the audience may say, "Oh yeah, I remember seeing that in the American Journal of Infection Control, or AJIC, a couple of months ago." At least I think it was a couple of months ago. But I think that really reinforces what you have been saying, that it's not a recent problem. This is an ongoing problem. So it's certainly an opportune moment to do something about that. Any other questions from the audience? Dr. Ramirez, I know always has a couple as well.
Are you going to read the question, Ruth? This in the chat.
I don't see any yet.
Well, there's a question here.
I didn't get all the way to the bottom. Okay, good. So let's see, I noticed in practice in urgent care where practitioners or doctors will provide antibiotics in patients with a heavy smoking history or COPD due to possible development of infection. Can you please comment on this practice?
Sure. So though we didn't talk about it very specifically here, COPD exacerbations, the vast majority of the time, are also caused by viral illnesses. There's a couple things in the GOLD guidelines, so increased sputum production, increased sputum purulence, that you're supposed to look at to help differentiate the likelihood of bacterial versus viral infection in those patients. So again, I would say that that's probably one of the areas of opportunity as far as antibiotic prescribing. And certainly here in Kentucky, with our high smoking rates, it's probably even more important for us than other areas of the country. So to, I guess, answer the question a little bit more fully, it's not always going to be inappropriate, but similar to the other disease states we're talking about, I would guess that we probably do have opportunities there as well, just based on what we see in those other disease states.
I see Matt also added some information about GOLD, the Global Initiative for Chronic Obstructive Lung Disease, that can also provide additional information and insight. Thank you.
Perfect. Thank you, Matt.
So if I can ask one more thing, I know that in looking at prescribing around the state, we think about all the different geography that we have, and that individuals may travel to a provider, especially in areas where it is more difficult to just deal with the terrain, or there are not as many providers. Then do you have any additional comments in about areas where the choice may be making a trip in to see a provider, and then what is some of the thought process then in in thinking, well, I'm going to send them back home, may be right, I may be wrong, they may or may not be able to come back in, or it may set up that cascade of increased illness and so forth. Any additional comments about kind of Kentucky specific?
Yeah, so I mean, that is a huge challenge in the rural setting, and I don't want to minimize that by any means. It's not always easy for our patients to come see us, and it's not necessarily easy for us to follow up. So in that setting, the probably pressure to write an antibiotic prescription just in case is going to be higher. And I think that that's appropriate for us to recognize. The couple things I think that we can do there to really try to make sure that that antibiotic is used appropriately would be really focusing on educating the patient. So talking to them about why an antibiotic may or may not be right for them. And one of the options that we also have would be giving them a prescription, but instructing them not to fill it until whatever day that's so far from symptom onset. Now, obviously, that's still up to the patient to follow those instructions, but that may be one thing that we can emphasize with them just to make sure that they understand the decision being made, especially if they're one of the folks coming into us and their instinct is just, well, I feel sick, I should get an antibiotic. They probably can benefit from more information as far as whether that's the most appropriate thing for them or not.
Great, thank you. Thank you. Someone else asked, what about prophylactic prescribing? Example is prior to dental work.
Sure. So prophylactic prescribing for dental work, most of the time is not appropriate. There's some certain like congenital heart defects and things where that would be appropriate. Those guidelines were updated a couple of years ago. So sometimes it's just a gap in knowledge for our dental colleagues. So I think that that would be one thing where, again, education to our colleagues as well can be really important with what's the most up-to-date recommendation on this particular practice and trying to just help them follow it. So that's one thing that we've talked about with the CASIC initiative is seeing if we can educate some of our dental colleagues as well.
See, another question regarding the map that you had in the presentation. Is there a reason why southern states have more antibiotic resistance than the rest of the country? And do you have any ideas?
That's a big question. So why do we have more antibiotic prescribing is probably the same as why we have many health disparities in the southern part of the United States. I think that things like lack of education, lack of access, all of those things really do contribute to that high prescription rate. So probably a holistic approach to addressing many of those societal inequities might help with antibiotic overprescribing. But that's probably not an easy thing to just snap our fingers and do better. I wish that there was a quick fix, but then I would be out of a job, I suppose.
I doubt it. I doubt it.
Find something else to do.
I was looking to see, I'd like to hear how facilities are educating providers, especially in long-term care, regarding stewardship. Any suggestions for providing education in this setting?
Sure. So I'm obviously very biased. I love antimicrobial stewardship. I could talk about it all day. I will say that I think that its emphasis in medical education is probably not what it could be just yet. So one of the things that we may run into is it may just not be emphasized in our physicians or other types of prescribers' didactic education. They may just be learning this is what you use to treat pneumonia, and those concepts of antimicrobial stewardship may not necessarily make their way into that early phase of education. So that's probably the first breakdown. The second is going to be in the setting of residency or fellowship training. Depending on who trains you, what the attending physician is teaching those folks, antimicrobial stewardship may not be something that they are particularly knowledgeable or particularly interested in. So it just may not be an emphasis for those prescribers. So in terms of long-term goals with antimicrobial stewardship, I think that we need more education just across the board. In those long-term care facilities, I think that probably doing targeted education to folks in long-term care is a huge opportunity for anybody interested in antimicrobial stewardship. So there's lots of particular CE or meetings geared towards those types of care settings. So I think that it's important, if we want to be having an impact that's widespread, that we are trying to work with those folks as well. Most antimicrobial stewardship programs exist in the hospital, but we also recognize that there are many, many opportunities outside of the walls of the inpatient setting. And I think that that's really the next phase of antimicrobial stewardship as a movement, is making our way into those other care settings where we can definitely have an impact as well.
I think Valencia made a comment just that kind of aligns right along with that, that we have so many NPs that are the primary care providers in rural settings, as well as in long-term care. And so not only taking that information, understanding reporting, but also taking that as an opportunity to say what education, what targeted education can we provide, and then meet those, those needs, and find out what are the best ways for providing this education. So this kind of blends right in with, I know what you and Dr. Wild and team are doing with CASIC, also what we are doing with the training center, and trying to provide information and find out how to do it in ways that are meaningful and valuable to those that need and want the information. So.
Yeah, I absolutely agree. And you can't do antimicrobial stewardship unless you believe that everybody just wants to do the right thing. So I think that a lot of it is just a lack of education around the particular nuance of the subject matter. And if you can get in front of folks and talk it through with them, I think that everybody is trying to do right by our patients. And that's really where education can make an impact.
Dr. Ramirez, I think we've covered the questions there in the chat. Anything that you have to add or close this out?
Good. I'm so pleased that there were so many questions from the audience. Good. Sarah, you give the consideration for development of multi-drug resistant organisms, and you put the list with the most serious ones that we have nowadays. How much do you think is the overuse of antibiotics in COVID in the early phases of COVID, meaning that we have overuse when the patient get admitted with COVID pneumonia, or how much is overuse in the late phases of COVID that the patient has been on a ventilator for 2 weeks, and we may have even overuse of antibiotics there, and you are addressing primarily the overuse when the patient get admitted, but any considerations, because these patients take an average of 2-3 weeks on a ventilator, any consideration for the question mark, just in case ventilator-associated pneumonia, that still are going to use even more antibiotics and more broad spectrum?
Yeah, so you're right. I did not touch on that problem nearly as much. So let's say that patient does have a multi-drug resistant infection, or even just a ventilator-associated pneumonia. I will say that anecdotally, I feel that a lot of our patients in that setting did receive at the upper end or longer than guideline recommended durations of therapy. I think that the other ID pharmacists were seeing similar things at their hospital. And I think a lot of that probably also played on our anxieties a little bit. These patients have ARDS, their lung function is not recovering. So when we've probably adequately treated the ventilator-associated pneumonia, but the patient hasn't clinically improved to the point that we wanted to see, our tendency is to just keep treating. And I think that one of the things that sometimes we would try to emphasize there, again, would be procalcitonin trends. If especially the patient had elevated procalcitonin that's now come down, that would be another thing that we could maybe use to quell a little bit of that anxiety. But I would say that those long durations of therapy are probably another issue that we were definitely seeing as well.
Very good. You mentioned the problem of antibiotic overuse and antibiotics allergies, toxicities, C. diff development of CD. What do you think of the data indicating that antibiotics may favor infections? That antibiotics, if you receive an antibiotic, you may be predisposed to pneumonia.
It's a good question. I mean, it's yet another thing to worry about, right? As if our list wasn't long enough. I think that
what do you think of the story of the antibiotics? I mean, changing our human microbiome, and we are doing things that we don't even recognize yet. And antibiotics may produce certain type of damage that we just started to figure out.
Sure, yeah. Oh, I mean, the idea that antibiotics alter our microbiome, it makes lots of sense, right? That's well documented in terms of how we see C. difficile infection develop. So the idea that the only thing we have to worry about is C. difficile when it comes to alterations in microbiome is probably an oversimplification. So I think there's probably certainly more for us to learn in that area. In terms of the microbiome, I think is something that we're really just starting to understand. So certainly interested to learn more throughout our careers.
Do you have any other question, Ruth,
No, so Ashley added a book on the topic. So they're links. So I'll make sure to keep the chat open and don't disconnect. Sometimes it's easy if you have an interest in one of the links, go ahead and open it while the chat is still up, so you can save it or download the article or document or bookmark it or whatever. So I think this is the great part about having this on Zoom, because then people can provide information very quickly that we can all take and go back and extend then the learning opportunity.
seems to be that there's another question, Ruth.
Yep, I see Mary said, what about antimicrobial items in the general public? For example, Dawn dishwashing detergent or Dial soap. I think what happens with the impact of these antiseptic agents or the antimicrobial agents on climate control, antimicrobial climate control.
I think that it's a good question that we probably don't have a lot of data around just yet. But yeah, I mean, again, the idea that we are altering our microbiome probably does have some sort of impact on us all long term. It is probably something.
Yeah. Hey, sir, this is Ash. Probably do a whole secondary topic about non-human use of antibiotics or non-therapeutic use of antiseptics and its role in the overall microbiome of an individual or the community, because I think there was another question about veterinary medicine, and obviously you started the conversation about moving from.
Oops, I lost you, Ashley.
Yeah, definitely touched on a topic that it seems like a lot of people are interested in, and we can always regroup and put together some more specific information about maybe extra, auxiliary use of antibiotics and how that affects what we're doing, even outside the country.
Yeah, I think that's a great point. And I think that the questions really speak to, I like that everybody's thinking about, well, like, what's the next thing? What's the next thing? Because it's probably not just antibiotics and viral illness, right? There are many, many opportunities. And that's the thing that's exciting about antimicrobial stewardship, is there are so many different areas where we have opportunities to improve our practices.
I think Mary brought up the issue that's been, one in infection control, and like, when do we need to use soaps with an antimicrobial agent in it? When do we need to use chlorhexidine? And when do we need, when is just plain soap and water hand wash acceptable? And I think it's, in our desire to continue to do more, that's a real slippery slope, both with antimicrobial agents and with antiseptics and germicides. And, all of those are very much interrelated. And both in terms of the psychology that we have around treatment and interventions, as well as some of the decisions about, well, if some works, then more must work better. And then, that takes us down a number of dangerous pathways. So I think this has been a great discussion and really bringing out, that this sometimes seems like a very simple question about antimicrobial stewardship, but we know it's not. And it has so many tentacles around it, especially in the field of infection prevention practice. That is, a partnership with our pharmacists and ID physicians and microbiologists and others. One reason why we have this type of summary grand round series. So this has been a great example. Great.
Well, Sarah, we want to thank you very much. Excellent presentation, excellent discussion. Thank you, all of you, for your attendance. And we keep in contact